I've borrowed Al Gore's title for my talk, Some Inconvenient Truths. Now, for a start, I have to describe some conflicts of interest. So I will start here. That's me as a little boy. That's my mother, Mary, who died in her early 60s, a terrible death in agony from breast cancer, God rest her soul. That's my kid sister, Linda, who developed breast cancer 15 years after my mother died. And thank God she was in the modern era where she presented early and had lumpectomy radiotherapy and 5 years of tamoxifen. And bless her, she's alive and well 25 years later, and I'm so happy for that. There are now 17 young women in my family, in the next generation, who are at risk of breast cancer. So my conflict of interest, number one, is that I am totally committed to seeing the end of breast cancer by 2020. My next conflict of interest, I have to declare, concerns the National Health Service screening program. This is Sir Patrick Forrest, who presented his report to Margaret Thatcher about mammographic screening. Curiously enough, it became public 2 weeks before a general election. I'm sure that was a coincidence. And on the basis of that report, in good faith, the National Health Service launched a program for mammographic screening to cover the whole country. I was given the task of setting up mammographic screening in the southeast of England, and then from there extending it, southeast of London, and from there extending it to the whole of the southeast of England. And this is the centre that we opened up in 1988 in a shopping centre and called Butterfly Walk. But this is one of the poorest, deprived areas of London, and yet we were reaching out to the poor, deprived women. So the second conflict of interest I declare is that I have been involved in mammographic screening from the start. Now, having declared those two conflicts of interest with a certain degree of irony, I've emerged as one of the most outspoken critics of the programme. Last October, the Marmot report appeared. Now, I led a campaign to expose the deficiencies of mammographic screening, and it was a coalition of consumers advocates and medical specialists who really understood the subject, saying it's not delivering to promise. And it's time the women were informed, kept informed, that it is not living up to its promise. So 25 years after the screening program appeared, the Marmot report, Sir Michael Marmot chaired this commission, and instead of resolving the problem, I thought they took the easy way out and kind of ducked the issue and tried to come up with a compromise. Now, this is the Times newspaper that reported on it, and the organisers, the government sponsors of this meeting, mischievously paraded a group of women at the press conference who declared my life was saved by screening. Now, I thought that was wicked, because no individual woman can claim that her life was saved by screening. So that was one newspaper, the Times, but the same day, the Daily Mail, which is read by most women in the country, came up with a different view, and by coincidence, it was written by me, and which actually pointed out what the Marmot Committee actually said. And the Marmot Committee said, if nothing else, women must be informed of the risk of overdiagnosis. And the Daily Mail found one woman who was prepared to say that her life was ruined by screening. Now, again, it's perhaps not possible to say that. So anecdotes tell you nothing. So we have to go back to basic principles. Why do we practice medicine? We want to improve quality of life, we want to improve length of life, and all other outcome measures are surrogates. So with each new group of medical students I ask the question, why do we screen for cancer? And almost always I get the answer, to catch it early, sir. They call me sir. And I say, wrong, because that means nothing. You have to reframe the question about mammographic screening according to what the outcome of medicine should be. Does screening improve length of life, and does screening improve quality of life? Now, how do we know how many lives or breast cancer deaths are avoided from screening? There have been 7 or maybe 8 randomized controlled trials of various quality that were recruited before we launched our screening program. Now that's 25 years ago, and the Forest report in 1987 came up with an estimate of a 25% relative risk reduction in breast cancer deaths. Since then, there have been some more reports. Your own US Preventative Services Task Force on 2 occasions estimated 15%. The independent Cochrane report on 2 occasions came up with an estimate of 15%, and the Marmot Committee decided they'd split the difference for no good reason, came up for 20%. But it doesn't matter what percent it is, there is no one in this room who can translate that into lives saved. And it's not because you're lay women, it's because there's no medical audience can do it either. There's probably only 2 of us in this room who can make this translation, because it's a hideously complex mathematical transition. And I'll just give you some rough idea, and don't worry if you don't get it. Just trust me on this. It is very, very complex. Now, in the era before tamoxifen, which was the era when we were recruiting into randomized controlled trials for screening, the 5-year survival on average was about 70%. So the 15 or 20% or 15% relative risk reduction was of that 30% who die in spite of surgery. But then comes tamoxifen, and the meta-analysis of 2000 showed us that the 5-year survival of women treated with tamoxifen is 85%. So if there's a constant relative risk reduction, it's that 20% of 15%. It gets difficult, and then as time goes on with a combination of chemotherapy and endocrine therapy and aromatase inhibitors, we've got about 90% 5-year survival of women presenting with clinical cancer who are then treated. So if we have a constant relative risk reduction, it's now that small window which has shrunk from the 70%. So it's difficult. I've done some calculations, and I really don't expect you to get your head around this. Not because you're lay women, because even my senior medical colleagues can't get their heads around it. So I've done the calculations. Others have done it. Many of us have done the same calculations. If you take 10,000 women, aged 50, and screen them for 10 years, you end up absolute benefits based, well, I've got either 20% relative risk reduction or 15% relative risk reduction. You end up with absolute benefits of breast cancer deaths avoided 4 in 10,000 women screened for 10 years, or 3 in 10,000 women screened for 10 years, which is a small number. And I want you to note that this is cause-specific mortality. This isn't saving lives, this is avoiding breast cancer deaths. Now, a woman's life is beyond value. It is valued beyond rubies, as the Bible says. So 3 or 4 per 10,000, it doesn't matter, they're lives saved, and saving one life is like saving the universe. But at what cost? This is why we come back to the issue of overdiagnosis and overtreatment. The conventional model of the growth of breast cancer, which seems to be fixed in the head of everybody, is that it's a linear progression. And you start off with duct carcinoma in situ. With the passage of time, you get node-negative breast cancer. With the passage of more time, you get node-positive, and then metastatic disease, either a linear or log-linear progression. Ergo, if you screen and pick up all these cases of DCIS, then the incidence of these more advanced cases will fall. It's obvious, isn't it? But, as one man said, an American I think it was, for every complex problem there's a simple solution, and it's wrong. 10 years after our national program started, a young colleague of mine, Michael Dweck, and myself, we decided to look at the impact of screening on the incidence in London. And these two blocks are the age group that weren't screened. And then this is the age group that was screened, and this is the incidence of duct carcinoma in situ in those that were screened. And that's the point at which there was national coverage. Huge increase in the incidence of DCIS, 20% of all screen detected cancers. One would assume, therefore, that the incidence of invasive cancers would fall. And here we have the same graphs. These are blocks that are not screened, the under 50s and the over 65s. And no, it's not the case. The incidence of invasive cancers go up. We could not believe this. In fact, we delayed publishing it for so long because I thought we had made big errors in our calculations that others got there first. And in 2009, Jorgensen and his colleagues published this, which you've seen. It's very similar to Gil Welch's group have published. And this is from the UK, from my country. Screening starts, incidence of breast cancer shoots up and stays up. And that is overdiagnosis. So women in the screening age group suddenly developed the incidence of breast cancer you wouldn't expect until they were in their 70s. So what is the rate of overdiagnosis? There are a number of estimates. The Cochrane report estimated that for every breast cancer death avoided, 10 women were overdiagnosed and overtreated. And then more recently, the Marmot report suggested that for every breast cancer death avoided, there were 3 women overtreated for breast cancer. But there are perils of overdiagnosis, you've just heard. And again, too much surgery, too much radiotherapy. And this is the British experience, which is the same as the American experience. And this was our study that I referred to before when we looked at mastectomy rates amongst the patients with early breast cancer. And I was picking up the pieces here in southeast London. These women came and they were told the good news is you've got early breast cancer, but the bad news is you've got to have a mastectomy because it's multifocal. This was very hard for me and a damn sight harder for the poor woman. And we found that with all this increase in the incidence of DCIS, there was an increase in the rate of mastectomy. And this wasn't just our findings. 10 years later, this is the, we're now going from 1988 to 2007. This is some work of Mike Dixon from Edinburgh, showing the increasing incidence of DCIS and the increasing incidence of mastectomy for treating, quote, early breast cancer. Then the issue of too much radiotherapy. This paper came out March, just a couple of months ago in the New England Journal of Medicine, showing that even with modern radiotherapy, within the first 5 years after treatment, there's a 16% increase in deaths from ischemic heart disease. And here's the table showing the numbers, years 0 to 4 and 5 to 9. This is the percent increase in deaths from coronary artery disease. Now, that's with modern radiotherapy, but at the time the screening trials were being recruited, we had old-fashioned radiotherapy when the risk of deaths from ischemic heart disease was 27%. Not 16, 15, 16%. So I tried to put this all together, and a few months ago I published this paper in the British Medical Journal. I'm not a maverick. The BMJ is a serious scientific paper. The paper was reviewed and refereed, so it's not just the ramblings of some maverick, as the screening lobby would like to point out. And I concluded that it was a close call. And this is the deaths from ischemic heart disease and lung cancer based on meta-analysis of trials from the period when the screening trials were reported, and then the benefits, which I've just described, of avoiding breast cancer deaths. And the conclusion was deeply disturbing. I didn't want to find this because of my conflict of interest. I wanted screening to be good, and I wanted to be knighted for my work in screening, Sir Michael Baum. So my wife is very upset with me because she wanted to be Lady Judy, and and she kept telling me, just, why don't you shut up? But I can't, because I care too much about women and the fact that they are being duped. So, to put this all in perspective, as I come to the end of my talk, here are 3 milestones as far as the UK is concerned. That's the first overview of adjuvant systemic therapy. The screening program is rolled out, and the Marmot report. The screening trials recruited then. But since the screening trials have recruited, there have been fantastic improvements in surgery, fantastic improvements in adjuvant chemotherapy, fantastic improvements in adjuvant endocrine therapy. Overdiagnosis has been recognized for a long time. I resigned from the National Health Service screening committee on this basis. Once it was obvious that we were overdiagnosing, I said the women must know. And I was told at a national committee meeting, if they knew, they wouldn't come. As they run that past me again, and I found myself in a minority of one. I had to resign and go public on this issue of overdiagnosis. Now, recognizing overdiagnosis, we've been able to embark on trials with partial breast irradiation, which are doing pretty good. And in fact, I'm speaking on this in Annapolis this evening. And all this has been going on, and our screening program is carrying on regardless. It's in a time warp. Instead of saying, yeah, it was a good idea at the time, but the data has changed, we must change our mind. No. But the good news is that treatment is getting better and better. And I know you've seen, you're familiar with these graphs now, and here the first overview of adjuvant systemic therapy, 1984-85. The launching of the National Health Service screening program, and you have to wait 7 years for any impact from screening, which is there. But look, the under 50s, the age group that's screened, every group of patients, of women, they're not patients, we can make them patients by screening, but most of the time where they're women, mortality rate is falling steeply, and it antedated the introduction of screening. And the most important point, again, to emphasize that the steepest fall in mortality for breast cancer in my country is in the under 50s who are not invited for screening. I was asked to say something about prostate cancer, but I think it's been said, other than to point out the fact that I happen to chair the National PSA Screening Committee, and we're doing a fantastic job called Protect, where close on 500,000 men are being randomized to PSA testing or not. And those who have a raised PSA and are found to have early prostate cancer then re-randomized to either active treatment with surgery or radiotherapy or active monitoring. When we set up this trial, we wanted to avoid the mistakes of mammographic screening. And so we will not be making the mistakes that you've heard about. We'll be reporting in absolute numbers. The outcomes will be measured in overdiagnosis and overtreatment, all-cause and cause-specific mortality, and we'll have the opportunity of studying the natural history of in situ disease. But I want to finish with an analogy to help fixate your idea what overdiagnosis means and where we should go to handle this. So this is a cloudy analogy. If you go out of doors on a summer's day and you see clouds like this, stratum, you know, you should know that it's not going to rain, it's going to be sunny. You bring out your sun umbrella, parasol. However, this is London. You see cumulonimbus clouds like that. They're also clouds, but you know to carry your umbrella. So what I'm saying here is that the weather is predictable. It used not to be predictable, but since we've incorporated chaos theory mathematics, weather forecasting is pretty damn good. We say that the natural history of breast cancer is unpredictable. Well, it's unpredictable because we're using the wrong mathematical model of linear or log linear progression. Breast cancer does not behave like that. It would be nice if it did, but it does not. And the only way to explain breast cancer and to make progress is to adopt an alternative mathematical model where we can look at clouds or look at shadows on the mammogram and say, I predict this is going to lead to bad weather. I predict this will not do anything of the sort. Finally, this is disgusting. You've no idea how awful this is. It's worse. You'll regret laughing, because this is a cartoon booklet for women with learning difficulties, and it's a cartoon strip of a woman with Down syndrome, coercing her to attend for screening. Yeah, I didn't think you'd be laughing at that. And of course, the double irony is that, as it happens, women with Down syndrome don't get breast cancer, or they've got more problems to think about than breast cancer. So I tell all my women friends, and I have many, oh, I shouldn't say that in front of my wife, caveat emptor, purchaser beware. And I tell you, once it comes to marketing screening, caveat emptor. Thank you.